Okay, Rista, go ahead. I'm recording it for
Okay.
sure. So Rista, if you could introduce yourself to everybody and once again repeat who Continuum is.
Yes. Let me just make this a presentation.
Yeah.
Just one
Up at
second.
the top. Up at the top. Yep, that's good.
Yeah, slideshow, right?
Yep. And just from beginning over to the left. Yep.
There we are. Okay. So, welcome everyone. I am Rista Luna. I am the family coordinator for CRS, which is our Continuum Recovery Services at Continuum of Care. It is one of the many services that Continuum of Care provides. Just like Deborah was mentioning, Continuum of Care has two branches. One is our developmental disabilities sort of a branch, and the other one is our mental health services. CRS is under the mental health services part of Continuum, and it provides residential services in various levels of care for people that has chronic and persistent mental illness and co-occurring disorders. We are a fairly new program, and we're unique in many ways in the sense that we provide more than just your traditional short-term residential for any kind of mental illness, but we also provide longer-term residential with a very strong community integration component that allows us to address sort of like the whole continuum of care, and allows us to see clients go from requiring a lot of services to pretty much being able to have as independent as possible of life, which is kind of our mission. So we are trying to do this family educational series in a way that we introduce the multiple disorders and symptoms that we treat. We've done already a couple of seminars on various subjects, including mood disorders and like in general, like what mental illness is. This will be our third seminar, and this is about anxiety disorders and obsessive compulsive disorders. And the one disclaimer that I would like to make is that we actually treat a lot of these symptoms mostly as secondary to the main reason that clients come here. But it's super important to learn about these symptoms because they can be sometimes as impairing or more impairing than some of the traditionally considered more serious disorders. So let's start with the presentation. So when is anxiety a problem? Anxiety is a problem when the symptoms are, again, impairing and interfering in the life of the person. So we do have a typical part of anxiety is avoidance, right? Clients or ourselves will stop doing things that we want to do or we did before because of the extreme anxiety that particular thing causes to us. And it'll affect our social functioning, especially, for example, if someone has social anxiety, they might limit the social functions or the interactions with others just to avoid, again, any kind of anxiety symptoms. And also, it's impairing when it interferes with aspects that are important to you in your life. For example, I really want to go to school, but I just can't tolerate going to school. I really want to start a job, but I just can't tolerate starting a job. Things that you might be very capable of doing and you very much want to do, but can't because anxiety interferes with every aspect of getting there, right? The decision-making process, to the getting yourself there, to the feeling capable of doing it sometimes. It is also a problem because of the degree of distress. Again, sometimes we face normal anxieties during the day, but we are able to overcome that anxiety using, our everyday coping skills. We're driving and there's a lot of traffic, and we might, put the music and feel better and be able to make it to our destination. But when we start avoiding, again, driving because it causes us too much anxiety, the degree of distress is such that is impairing. And the other aspect of anxiety being truly impairing is duration. Again, an occasional anxiety or intermittent anxiety that happens throughout the day. We're like late for a project, or we didn't study for a test. That might be normal anxieties in life. But when anxiety is overwhelming for most of the day or for days on end, then it can cause even physical symptoms, and therefore be more impairing. Risk factors, there's always a number of things that cause most mental illnesses. Mental illnesses are multifaceted, and they don't actually have one cause that can explain the whole thing. So there might be some disposition or personality factors like shyness, or a natural tendency to be more nervous than most people. There might be also some traumatic experiences in the past, and there might be a biological history of anxiety or other mental disorders, meaning we might have a family history of anxiety, a family history of someone else suffering from anxiety. In general, what I would describe about anxiety is that someone that suffers from an anxiety disorder does not have the same baseline that people that doesn't suffer from anxiety have. In other words, let's say if you do a scale of 1 to 10, when we're not anxious, people that doesn't suffer from anxiety might be on a 1 or a 2. And then when they get really anxious, they get to like an 8 to a 10, right? Someone that suffers from an anxiety disorder, when they're not anxious, they might start at a 4 of a 5 or a 5. So the range that they have to manage their anxiety is a lot less. And then that reduced range happens because of biological factors, learning factors, or trauma. Regardless of what the cause is or the combination of causes is, one of the main, and if you talk to someone with anxiety, one of the main things that people with anxiety might tell you is like, I'm never relaxed. Like I'm always anxious, even when I'm not anxious. And therefore, sometimes my coping skills don't work because I'm already starting again at a mild anxiety. So that's another impairing factor when you talk about anxiety. Types of anxiety. There are many diagnoses, and again, even if you don't officially have a diagnosis of any of these disorder, you might experience some of the symptoms of this. And they might still need to be addressed through therapeutic interventions. And those are the things that we focus on when our clients come here. Sometimes they might not come again for a primary diagnosis of anxiety, but we know that some of these symptoms need to be addressed for them to be able to move on and treatment to be effective, especially when we're talking about community integration and achieving of independence. So one of the diagnoses that is most common about anxiety disorder is generalized anxiety disorder. And this will be your very anxious person. Basically, if you ever call someone a worrier or a worry worm, this is your worry worm. This is the person that is worrying about things, and when something it's resolved, we find something else to worry about, because that's just how their system works. And generalized anxiety disorder is one of those anxieties that can last for months, if not years, because again, baseline doesn't go below a 5 or a 4 of a 5 when we're talking about anxiety. We'll talk later about interventions, so let me just describe this a little bit, but there are different interventions for different kinds of anxiety, and I think that will be very useful as well. Panic disorders are more like sudden periods of intense fear where the person feels that they're losing control, and this might be with a team or without a team. When you are diagnosed with panic disorder, most of the time you're diagnosed with panic disorder when you like simply are afraid of being anxious. So panic disorder is almost like fear of anxiety itself. You might not have an identified trigger. In other words, sometimes you might have increased anxiety, again, because of a test or because of a social situation, and the symptoms might be very similar to the symptoms of panic disorder. But with a pure panic disorder, you simply are afraid that you're going to get anxious or afraid that you're going to get sick if your anxiety gets too high. It's anxiety about anxiety. Social anxiety, as the name says, is mostly anxiety about social interactions or social situations. It also can be accompanied about extreme concern about being judged or embarrassed in contact with others. So that's important to understand, because sometimes, someone might feel or look like they're very gregarious and like, oh no, you don't have social anxiety, but inside they might have a lot of concerns about what other people are thinking, or how are they being judged, or if they're gonna perform adequately in a social environment. So that might also contribute to social anxiety. And then you have your specific phobias, which are also very common anxiety, and sometimes people goes and least with specific phobias. And I mean, even though there's like very good treatments for them, sometimes we like don't really feel them as impairing or in need of treatment, right? But like these will be your fear of snakes, spiders, elevators, and some of us, basically like try to avoid those things, right? Like if we were afraid of heights, we might never go into the amusement park and take one of those scary rides. Or if we're afraid of snakes, we might call someone to help us every time we see a snake or a spider, right? And we might not address that anxiety because we don't find it as impairing, or because we can avoid the specific trigger of that anxiety. We were talking a little bit about a panic attack, but a panic attack is basically an abrupt feeling of intense fear and discomfort that reaches intense heights within minutes. And the symptoms are very physical, and people sometimes will report and show up to emergency rooms complaining of like a cardiac event or a respiratory event, only to find out that after many testing, there's nothing wrong with them. And this can be very frustrating, especially for someone that has not been diagnosed yet with panic, or doesn't know that they suffer from an anxiety disorder, because again, there might not be a specific trigger. All of a sudden you feel chest pain, you feel abnormal sweating, you start shaking, you start having difficulty breathing, and you're like, there's something wrong with me, and I don't know what it is, but it feels very, very medical. And you might seek medical attention only for a doctor to say, there's nothing wrong with you. And then you have it again, and the doctor says, there's nothing wrong with you. It is an anxiety disorder. There are ways to address it and minimize the occurrence of panic disorder or panic attacks. But it's important to know that when someone might have these physical complaints, or might tell you, I've gone to the doctor, I've been to the ER like every week or something like that, and like, I think I'm going crazy because the doctors keep telling me that there's nothing wrong with me, they might be having a panic disorder, and they're really not going crazy. They're having real symptoms, and they're having, a diagnosable anxiety disorder, which again, we'll go into interventions in a little bit, but they're effective interventions, both behavioral, meaning like therapy-wise, and medication-wise. So here it's where I was talking about a little bit. They're situationally based panic attacks. And this is when there is a cue, right? If you have social anxiety, and you're in a very stressful social situation, you might experience a panic attack, but you know it is because you're in a social situation. Or if like you live your life avoiding spiders and all of a sudden there's no one there to help you avoid that spider, you might have a panic attack, but you clearly know that that's happening because there's a spider there. There are also the situationally predisposed panic attacks, and these also occur in response to a specific trigger, but the trigger can be present or not. So you might just remember something that was very upsetting to you, or you might have done okay in the very, very upsetting situation, and then 2 hours later, when you go home and you decompress, you have a full-blown panic attack because you tolerated this sort of party where you were very uncomfortable the whole time. And then there is the unexpected panic attack, which is your true panic attack, where you just have a panic attack and you have no idea why you have it, and you might not even know that you have an anxiety disorder. And those are the ones that cause probably the most distress to people and might take a while to diagnose. And a lot of people go through, again, a lot of medical testing, a lot of like different doctors and a lot of second opinions because they can't believe there is nothing wrong with them. And the truth is, there is something wrong with them. They're just looking in the wrong place. But yeah, these are probably the most distressing and the harder to diagnose type of panic attack. All right, let's talk a bit about obsessive compulsive disorder, and hopefully we'll get to also some management and interventions. So obsessive compulsive disorder, again, as the name says, will present with obsessions and compulsions or both. And that's important because in the past, if you know what the DSM diagnostic system is, the DSM require both obsessions and compulsions to diagnose with obsessive compulsive disorder. Currently, both are not necessary. It's either or both. And I'll go into I think this is really interesting. This is one of the disorders that sort of interest me the most. So I'll go into a little detail, more examples about this. But obsessions are recurrent and persistent thoughts, urges, or impulses. So there are 3 characteristics to obsessions. They're recurring and persistent. They're intrusive and unwanted, meaning that you don't like them. Like someone that might have an intrusive thought might actually agree with that thought. Let's say if you're really depressed and you're thinking that you are not a good person, if you're depressed, you will think, well, yeah, I'm right, I'm not a good person, even though that might not be true, right? But if you have obsessive compulsive disorder, your brain keeps telling you you're not a good person, you might be thinking, why am I thinking that I'm not a good person? I'm actually a good person. Why can't I not get rid of that thought? So there is a slightly different sort of theme to an intrusive thought and an obsessive compulsive intrusive thought. And the main characteristics and how you know that this is OCD, it's because it's unwanted. It's what we call ego dystonic. You don't agree with the thought, but cannot get rid of it, basically. And let's just the most common thoughts, right? Things might be contaminated and I need to wash my hands. And I might say, even though I have that thought, I might say to myself, why do I keep thinking this way? I know this is clean. I just cleaned it, but I need to clean it again. So ego dystonic. I do not agree with the thought, but I cannot get rid of it. And it causes marked anxiety and distress. And usually it doesn't resolve until you complete the compulsion, meaning the only way to reduce the stress of that ego dystonic thought is to actually do what you think you need to do. Now, this is where it gets tricky. Compulsions are repetitive behaviors, and those are the things that we're used to know as OCD. So hand washing, ordering things, checking, locking and unlocking doors. Those are the very visible compulsions. And some people with obsessive compulsive disorder will really use those compulsions to decrease the anxiety of the unwanted thought. A lot of OCD symptoms are actually mental compulsions, and those we don't see, and they're very, very hard to diagnose. So mental compulsions are praying, counting, repeating words silently. So you don't really know that the person is engaging in the compulsion, but they are. Another common compulsion is to keep thinking about the whatever theme is of the day, whatever the obsession is, and try to solve the problem. I've seen a lot of OCD happening where, for example, you worry if you did something right or wrong. Let's say you did a presentation like this one, right? And then this presentation finishes and I'm like, what did the presentation go right? Did it not go right? Let me check again. Oh, I forgot one word. Let me check again. Oh, I didn't do this. That is also a compulsion, checking on your own thoughts. And it's really, really difficult to diagnose OCD, and it's really, really difficult to find out that it's OCD, because that can be just a very perfectionistic person trying to do things right. But the one thing that gives you the cue that this might be OCD is the fact that, again, it's an ego dystonic thought. It causes distress, and the person cannot stop doing what they're doing. They have to continue to engage in the compulsion, which in this case is a mental act, to reduce their anxiety. Like the last point in here, the individual feels driven to perform the act in response to the obsession. Obsessions or compulsions are time-consuming and cause significant distress or impairment in social, occupational, and other important areas of functioning. So even though this diagnosis is not some diagnosis that might get you into the hospital or might get you into a residential setting like this, it is quite impairing, and it be something that in a setting like this will be working to address so that independence can be achieved by the person troubled by obsessive compulsive disorder. And again, the difference in between an OCD thought and a more psychotic thought is that the person that has OCD, it's very, very aware that these thoughts are not real, that these thoughts are intrusive, and would like give anything to get rid of them, and yet they cannot. Finally, the last type of anxiety is anxiety related to trauma, and that is post-traumatic stress disorder. Trauma, it's a whole, I mean, I could do a whole other presentation about trauma and how it presents. This is just a brush over, anxiety related to trauma. But basically, at any traumatic experience, either that you suffer, that someone that you love suffer, or some vicarious traumatic experience. Think about all the people that saw the events of 9/11 on TV, for example, and how many of them might have had some PTSD symptoms after they saw those things. Things about, people that might hear horrible things that happen to a loved one, and then they might lose sleep over that, because they just only can imagine what happened to that loved one that was in trouble. So either you are exposed directly, someone else that you love is exposed to the traumatic experience, or you're exposed vicariously, meaning, via the news, via TV, via a book, via another sort of source of information. You might develop PTSD symptoms. PTSD symptoms will develop depending on the severity of the trauma. And again, it can be in many ways. The duration of the exposure, think about people like that are in situations of war, or, people that came out of concentration camps, or people that is exposed to persistent poverty, or, unhealthy or unsustainable living conditions. That might be a trigger for PTSD as well. And then who is the person that was involved, right? How connected am I to that person? If I was able to dissociate during the trauma, again, we'll probably talk about dissociation in another educational series, but dissociation as part of a diagnosis might be some sort of unhealthy coping skill. But think about the person that really doesn't pay attention to what's going on while the traumatic experience is happening. That might actually be protective for them. So if they're able to like protect themselves by not being involved with what's going on at the time of the traumatic experience, they might be actually protecting themselves from developing PTSD symptoms in the future. And also pre-morbid functioning, meaning, did you have trauma before? If you have trauma before, another traumatic experience happens, the chances of you developing PTSD increase. If you already suffer from depression or anxiety and then you're exposed to a traumatic experience, that might also increase your chances of getting PTSD. And the extent of social support, how supported you feel, who can you go to after this traumatic experience? Can you talk about what happened? Is help immediately available? Do you feel like you will have enough support, to deal with this situation? So, I would open the floor a little bit for conversation. And these are some suggested questions, but I will welcome you to ask any questions about anxiety, OCD, or PTSD that you might have, or any comments that you might have before we continue with the presentation. Hi, Liz.
Hi. Did you refer kind of briefly to, did you say that when someone has OCD and they don't recognize it, it is psychosis?
No. What I'm saying is the difference in between psychosis and OCD is that with OCD, you are very clear that your thought is intrusive and you generally don't want to have it.
Yeah, but when you have whatever psychosis, you don't
necessarily,
you believe those thoughts instead of recognize them as intrusive.
Correct. That's the difference.
Okay. I mean, I didn't state what you had said, right? Thank you.
Yeah.
Get dog hair on me.
That's cute. I think with OCD, the main thing is how torturing those thoughts are. They really are something that the person would rather not have. With other disorders, psychosis or depression or even bipolar illness, the thoughts are not necessarily that distressing. Like, you agree with them. Yes.
And the other thing earlier, am I on?
Yes, you're on.
Earlier, with anxiety, you were saying that people don't, I think you were saying that people don't want to have it, but isn't it just as possible that they don't even recognize that they have anxiety? Not that they want it, or you're right. Okay.
Yeah. So with anxiety, especially when you talk about panic, you sometimes don't know that you have anxiety. Anita, I think you have your hand up.
Oh yeah, sorry.
Yes, thank you so much. Thank you so much for this interesting and very to the point presentation. I have a follow-up question. This is very interesting. So a person actually who doesn't recognize both anxiety and has these compulsions in OCD.
Anita, I am so sorry, but I'm not able to hear you well. Can you somehow repeat it or type it in the chat, maybe?
Okay, is this better?
It's better. Go ahead, try.
Okay, let me try. I'm just following up on the prior discussion. Before that, I said thank you so much for your presentation. So a person who does not recognize with anxiety and also the OCD is most likely to have psychosis. And my loved one has been diagnosed with psychosis, is very gregarious and outgoing. So it's really, he doesn't recognize it, and others around are thrown off because he's outgoing and gregarious, but I can see the constant anxiety, which doesn't help the OCD, right? So my question is, so my question is, how do you treat something like this? Are antipsychotic medications, behavioral therapy, or what do you think is most effective?
So that's a very hard question, because for the specific case, someone will have to do a complete assessment and figure out what's the best intervention. In general, psychosis is best treated with medication. There are some cognitive behavioral approaches that are very effective for psychosis, and some of these cognitive behavioral approaches are effective for psychosis and OCD, because of both thoughts are intrusive, and people has a hard time getting rid of them, regardless of you believing them or not believing them, right? Psychosis is there and doesn't leave. OCD is there and doesn't leave. So in terms of therapeutic interventions, CBT, cognitive behavioral therapy, has a couple of techniques that work really well with both. One of them is it's a combination of mindfulness and behavioral intervention. So just briefly, this will have to be a whole class, right? Briefly though, if you have thoughts that you cannot get rid of, the recommendation of these therapeutic interventions is don't even try. In other words, instead, like with other disorders, you do a lot of cognitive restructuring, you do a lot of cognitive disputing so you can change your thoughts. With OCD and psychosis, you don't even try, because you're not going to kick them out. Those thoughts are not going to go away no matter what you do. So what you do is you basically accept the thought and let it be there. So it's called exposure therapy. And exposure therapy basically allows you to feel the anxiety until it goes to a point that it's intolerable, and that just because this is how our bodies work, once you get to that point, the anxiety goes down, and once it goes down, your body gets used to those things, those thoughts being there, and you can just tolerate them being there. There's a number of mindfulness exercises to teach clients this. There's a number of cognitive ways to basically talk to yourself, so to speak, and say, okay, I know you're not going away. I'm just not going to pay attention to you, thought. So that's in terms of therapeutic interventions. Honestly, if there is psychosis, the first line of defense will be medication management. And again, medication management for both OCD and psychosis is, it's something that has to be personalized. There are like a number of antipsychotic agents and anti-anxiety medication that can be used. Not all the combinations work. So that's something that really a psychiatrist will have to answer. But definitely, if you have some, and just a brief intervention when we talk about psychosis in a future seminar, we can do more about this. But one of the differences between psychosis and OCD is with psychosis, you have what it's called anosognosia, or the inability to recognize that you have an illness. So in other words, someone that is psychotic will have a hard time even thinking that what they're thinking is wrong. They have no problem with what they're thinking, and that becomes, like you, Anita, were explaining, their downfall, right? Like they think they're doing fine, and maybe they're like super attractive to other people because like they're gregarious, like your family member. So they find no reason to change. They're very comfortable with their symptoms, even though they might be destroying them. So again, first line of attack for psychosis, medication, CBT techniques for exposure, very effective to not necessarily eliminate the thoughts, but tolerate them and ignore them. Decrease the value of the thought. That's what you do with these two illnesses. So if the thought is not that valuable, then you are able to live with it, even if it doesn't live. All right, let's continue. All right, here are some resources for the treatment of various anxiety disorders. I will send this to you. I think that during this part, I also want to share with you a couple of therapeutic interventions for all of the diagnosis. So let's start with anxiety disorders. With anxiety disorders, like generalized anxiety disorder, panic disorder, even the specific phobias that we've talked before. First line of defense, again, medication management, especially for panic disorders. There are controlled substances that are used to manage anxiety, and they're like non-controlled substances that are used to manage anxiety. Panic disorders especially do respond very well to benzodiazepines. The risk with benzodiazepines is their habit forming. And when I think habit forming, there are two risks, right? One is addiction, and the other one is tolerance, meaning the person will need more of the same medication to get the same effect. So doctors usually prescribe those medications as a PRN or as needed to minimize the use unless it's absolutely necessary because the person is in the middle of a panic attack. They are for, again, anxiety disorders and specific phobias, SSRIs do work really well, especially actually the older SSRIs. So Luvox, Prozac, Zoloft, which are like the older SSRIs, not the newest ones that work better for depression, do work really well with anxiety disorders. Same thing with OCD. In terms of medications, Luvox is probably the first line of attack if a psychiatrist is going to prescribe medications, as the other older SSRIs will be prescribed as well as first. For OCD, exposure therapy, it's sort of the state-of-the-art treatment. Exposure therapy can be done with in stages. It's usually done best with a therapist that it's really hands-on and it's well-trained on, again, cognitive behavioral techniques. And actually, it could be quite fun for the therapist and the patient to do it, because it allows them to empower the client to gradually expose themselves to the things that they would not have exposed themselves in the past. That works also really well for the specific phobias. If you ever want to not be afraid of spiders, you can find someone that can teach you exposure therapy, and it works. Personal note, the main diagnosis for my child, I think we've talked about before, it's actually OCD, and she practices really, really well exposure therapy. And she actually, she still has the intrusive thoughts and what have you, because she really has the diagnosis. But she actually has learned to use exposure independently and have fun with it. And right now, if we have a conversation about an OCD symptom, it'll be as simple as like, Mom, that's my OCD, right? And I'll be like, yep, that's your OCD. Okay, I know what to do. So it does work. And it really, it really empowers the client to intervene with that. And then for trauma and PTSD, there are a couple of options. This is one that I would call it an acquired sort of illness, or like not something that is genetically based. So medication management it's not sort of the first line of defense for post-traumatic stress disorder. Actually, therapeutic interventions are the first line of defense. Two trains of thought on that. DBT works really well with emotional regulation, and that is a great deal of what happens when you have PTSD. The inability to manage your emotions and the inability to manage the stress from the events that remind you of the past traumatic event. So DBT works really well with emotional regulation. And then insight-oriented therapy, what used to be like psychoanalytic and dynamic approaches, because it allows the person to really work through the trauma and sort of process it because it was not processed before. With PTSD, you are managing, if you're using medication management, you're just managing the symptoms. In other words, if you can't sleep, you can find something for sleep. If you are having a panic attack, you can find something to manage the panic attack. Sometimes SSRIs are used also for the baseline anxiety, because as I explained before, with anxiety in general, that gets you to a 5 instead of a 0. So to extend the range, SSRI sometimes work. So if if an SSRI can work, bring the baseline of your anxiety to a 2 or a 3, you have more of a range to use coping skills on that, range of anxiety. So I think that's it. Unless you guys have, let me see. Yep, that is it. So if you guys have any questions or want to discuss any specific case, I think I still have about 15 minutes that we can talk about. Yeah.
Just to give advice to everybody, my daughter's been through a lot since she was middle school up to now she's 30. And one thing is very important, that you do set boundaries, no matter what the diagnosis is, for yourself, to handle your stress level, especially if somebody talks repetitively about something, they're worried about something, it can cause anybody who doesn't have that, but you start becoming anxious a little bit, and then you get, I will get a little bit angrier, and I have to stop, put the stop sign up and just stop talking about that. It'll work out, and we're in the present day, so it will take a lot of therapy, and it will never be cured necessarily, but there like Rista said, there's therapies out there, exposure, Continuum is wonderful. It's been wonderful for my daughter. I live in Virginia, Melanie's in Connecticut. And so all I can say is just keep at it, just have patience, and do as much research as you can.
And Melissa, you bring up a very good point. Actually, that's exactly the difference in between dealing with a normal anxiety and OCD. When you deal with normal anxiety, you can dispute thoughts, you can reason, you can try to find a way of changing the way that they see things. With OCD, actually saying we need to stop thinking, we need to stop talking about this, or we need to stop thinking this way. It's probably the best intervention. Let's just not pay attention to that line of thinking right now. Let's distract ourselves. We're not going there. Not happening.
Right.
And that's not limit settings. Actually, that's part of exposure therapy. And that's part of a great intervention, because again, it's not OCD thoughts like psychosis. They're just, they don't go away. It does not go.
Yeah. It's not gonna go. It's just,
and it's just worrying. It's not going to do any good. It's ineffective. So it's like, for every individual, it's whatever their coping skill is, whether it's like putting a frozen orange in the freezer, and then holding that, taking your mind off what's going on in your mind at the moment, redirecting your thoughts, just kind of, believe me, I've been through a lot with this. So it, but you also have to set boundaries for yourself, because, my daughter's an adult, so I've learned I have to have boundaries with her. And, the situation is what it is. So make sure you get a really good psychiatrist if you need to get medication, and really get a good diagnosis in it. Unfortunately, their brain doesn't develop fully till 25. So we really didn't get a real full diagnosis until then. And some of these medications can interfere with an illness that's going on that you don't even know they have, and that's the sad thing about the whole thing. But
yeah, and the tricky thing, just from my own experience too, is like sometimes you get tangled in this like checking or worrying, and you're like trying to, again, your natural, especially as a parent or as a family member, your natural tendency is to try to console and try to, help them, and then you realize that not gonna work.
it's not going to work.
Stop it. It's the right intervention. Stop it. Let's move on. Let's think about something else. Let's engage in a different activity. That's the best intervention.
Yeah. Thank you, Rista, for having us today.
Rista, I don't know if you saw Amy put a resource in the chat box.
Well, I saw in the chat box, would CBP, what's CBP? There's a question
it's actually CBT.
Okay.
Yes. CBT.
Okay, I know that.
Yeah, CBT. There's also within the CBT modalities, there is ACT, acceptance and commitment therapy, and that's basically leave the thoughts there, do nothing about them. That's another good sort of branch of CBT that can be used very effectively for OCD.
So Rista, I don't know necessarily if we're talking. Well, wait, is the therapist or diagnosing doctor working on these kinds of therapies with the clients? Okay.
Yep. Yeah. So obviously the prescriber will work on the prescriptions. Here I'll continue, the therapist will do the therapeutic interventions. If you are an outpatient and in another setting, there's possible there are psychiatrists and APRNs that do both therapy and medication. But again, state of the art for OCD is CBT, specifically exposure, and ACT, acceptance and commitment. But yes, thanks, Amy. I see the resource in there. There is also an app if anyone is interested, and this that you can use for actually your family member or yourself, is NOCD, and it has tools and even like ways to like actually stop yourself if you don't have someone to tell you to stop, things to distract yourself, sort of like people that can post like educational things about OCD and other things, and it's a free app, so you can download it. I think like if you end up getting a therapist through an OCD, then you have to use your insurance and stuff like that. But there's the other resources in the app are free and useful for someone that wants to have an additional tool to do relaxation or have resources.
Could I ask a question?
Yes, please.
Okay, thank you. This is actually a response to a statement that was made this evening that a child's brain is really not fully developed until they're 25. And so you really don't know precisely a clinical diagnosis until then. Is that correct?
No, remember that the diagnosis is a list of, is a syndrome. In the case of psychiatry, diagnosis is what we see now. What you need to be aware of is that what we see when your child is 12 is not what you will see when your child is 16. It's
Okay.
not what you will see when your child is 25.
Right.
When you see now, what you see when your child is 25, when you see when your child is 30, more it's doesn't change that much because brains have stopped growing at that point. But so, like, again, this is my typical example about this, right? A kid has their first mood disorder episode when they're like 16, they're depressed. So the doctor tells you your kid is depressed.
Yeah.
By the time they're 18, they have a manic episode. Now your kid's not depressed anymore. Now your kid has bipolar illness, right? But you didn't know until then because you've only seen one side of it,
Oh, okay.
right? Or again, with OCD, someone might diagnose your kids with generalized anxiety because they're worrying all the time, only to find out that they're worrying all the time because they have intrusive thoughts. But you won't find out that until later. So,
You know, my question related to all of this is the following. I know someone in my family. She's just turned 17, and she has been verbally abused by a parent. So it's taken its toll, and I just wonder: is it just about the patient himself or herself, or is there some kind of behavior modification that is directed to the person who's actually inflicting abuse? You know, I worry that sometimes these young teenagers are looking at everything from their perspective instead of trying to have some kind of a focus, some kind of attention to the person who's, say, verbally abusing them.
So that's a very good question. And my general answer to that would be family therapy is always a good thing for anyone, teenager, young adult. You know, if you go and see things from the family systems perspective, a family systems therapy will tell you that when one of the parts of the system is sick, the whole system is not functioning well.
Right.
So the issue is that you have to address it both ways, right? Because sometimes the other parts of the system, I mean, and you guys are here, and I know some of you, and you are systems that are trying to do your best to help your kid, right? But there are other systems and other families that might not necessarily want to believe that they have to do anything to fix the problem. And then you have to arm that kid or that young adult or that adult with the best tools you can give them so they can do it on their own. Not ideal, right? But not all systems respond the way that you guys are responding.
Well, I just is there room for spirituality in all of this?
All the time.
Okay.
I think that spirituality is one of the things that we pursue and incorporate as part of community integration, and as part of you know, assuming an independent life. Obviously, you know, when you talk about a therapeutic intervention, we wouldn't like lead someone into any particular spiritual practice because that wouldn't be appropriate, right? We're here to like encourage their best self. But when they find their best self, if spirituality is part of that, we absolutely encourage them, and it's beautiful to see them to find sort of connections that they didn't have before, or, you know, they might have grown up with a certain cultural background that they didn't embrace, and then they start embracing. So absolutely, and it does help. And when it's their thing, you can see how they might be super anxious, for example, and then they, you know, they go to church or they do some spiritual activity, and they're better because that's what brings them joy.
Yeah.
But yes, absolutely, there is always a place for that, and it's a very important part.
Good. Thank you.
All right, guys. Well, thanks again. Go ahead, Anita.
How does cognitive impairments further complicate the situation?
I'm sorry, but I couldn't hear you again. Can you try again?
How much also cognitive impairments play a part in this? The OCD or cognitive impairments or developmental delays, they create anxiety also. And then down the road, you have this OCD situation. And, it's just such a complex profile, and how to go about it and what to prioritize.
So I couldn't hear you well, but I think you were asking, how do you encourage someone to engage on this kind of therapy, right? CBT. And how do you help them understand and find out that this can help?
I mean, yes, but help somebody who also has, who's on the spectrum.
So actually, if someone is on the spectrum, sometimes the symptoms are very similar to OCD, and the same interventions do work. I think that when someone is on the spectrum, you have a more behavioral approach, meaning that the interventions of CBT might be more to change behaviors rather than thoughts. A common thing that is used in general for people that are in the spectrum is behavioral charts, what is called operant conditioning, or basically rewarding or finding rewarding ways to encourage positive behaviors and positive intervention, and practicing extension, or basically not encouraging behaviors that are detrimental. There's a whole sort of training for people that does these behavioral interventions with people that are in the spectrum. But this, it's the same intervention. For OCD, you do not try to eliminate the obsession, because it's not going to work. You try to help them tolerate it, and you might use slightly different approaches, and the approaches for someone in the spectrum will be more behavioral, but still same principle.
Okay, thanks.
Yep. You're welcome. All right, well, I would send the resources to you, as well as a copy of the presentation. Thanks again for being here and spending this time. And if you have any questions, you have our contact information, and we'll be happy to answer. Have a good night.
Thank you, Rista.
Bye-bye.
Thank you, Rista. Bye-bye.
Bye. Bye.
Hazel says goodbye.